webinar from COVID series. And this is a very, very important webinar today regarding, our topic today is safeguarding healthcare workers and health facilities. Today, we're going to focus on COVID-19. As you know, there are different waves of COVID-19, and now there's expectation that there's going to be another wave, second wave of COVID-19. Some areas already seeing rise in numbers, and being healthcare providers, I think it's our utmost duty. Number one is protecting our patients, and number two is protecting ourselves against any infections. So we have the way this webinar is going to be. We thought we have three speakers today instead of having panelists. So our three speakers, they are all, mashallah, esteemed presenters, and they have accomplished in their fields. They are all family physicians, and they will talk about healthcare, safeguarding healthcare workers, and also talking about how to look after our healthcare facilities. So we have Dr. Unab, Dr. Abdul Waheed, and Dr. Yousuf Haroon. Let me start with Dr. Unab. And Dr. Unab, mashallah, she's participating in our COVID series for a very long time, almost weekly, on a weekly basis, and she's very active in our family medicine program for Pakistan. Dr. Unab is an associate professor and chair of family medicine at Khan University. I will, without taking any more time, I will give it to Dr. Unab. Kindly introduce yourself a little bit more and go ahead with your presentation.
Sure, thank you. Assalamu alaikum, everybody. Good morning, good evening. I'm Unab. I'm chair of the Department of Family Medicine here at Khan University, but I also wear that extra hat of being the Director of Employee Health and Safety at AKU. So what we are going to do today is that I will start the presentation and kind of talk about the framework to discuss how healthcare worker safety and healthcare work settings safety have been looked at by the WHO and by other institutions when the COVID-19 pandemic broke. And then the three of us as speakers will talk about our different experiences in our own healthcare settings. And hopefully you will be able to derive some information from it that you will find useful to put and apply in your own settings. So without talking more, I'm going to just stop my video and then share my screen so that there's enough bandwidth to do that. So let's begin. Okay, can everybody see my screen?
Yes.
Okay, thank you. Let me just change it to the slideshow. All right. So as we said, it's really talking about safeguarding healthcare workers and healthcare facilities over here. I certainly don't have any conflicts of interest to share with you, which will make a difference to this presentation. And our objectives really are threefold. Number one is to discuss how to keep healthcare workers and healthcare settings safe during the COVID-19 pandemic, but then also to share another area where family physicians can take the lead. I think that is one important thing for us to talk about, of how many different roles family physicians across the world play, and where we can see ourselves as being extremely useful to the healthcare industry. And then finally, to discuss healthcare worker safety in different parts of the world, which will be done both by me but also by Dr. Yousuf and Dr. Waheed. So this is the situation of Pakistan. We've all probably seen this graph. We had our biggest peak came up in June, and July is beginning, and then slowly we saw a decrease in the number of positive tests, positive COVID patients. However, we are now starting to see a peak again because, of course, we've stopped wearing masks, and there is a concern that there will be a second wave coming up soon. Now, when we talk about healthcare worker infection, it is really important for us to think that, you know, this exposure and the resulting of infections in healthcare workers and hence depletion of trained personnel to provide care to the public is an international challenge. In some areas, it has happened because of inadequate PPE, while in others, it is due to poor planning for the surge. And now ensuring healthcare worker safety is really important, because not only can you provide much needed care to critical patients, but also so that we can prevent the spread of infection to vulnerable patients who we take care of. And our biggest goal during the COVID-19 pandemic has been to prevent hospitals and healthcare settings from becoming hubs of infection rather than taking care of patients. This data was published in MMWR, which is the Morbidity and Mortality Weekly Report. It's a CDC publication in the US, and to date, it is the largest data which is published about healthcare workers. In this, they looked at between February and April 9th, about 315,000 COVID-19 cases which were reported to the CDC, of which 10,000 people approximately reported that they were healthcare workers. Now, this graph shows the general population in the light blue and the healthcare worker infections in the dark blue. And what we can see is that as the infections in the communities increased, so did the infections in the healthcare workers. And what we find is that in 85% of the healthcare workers, they really could not identify who they were exposed to for them to get the infection. So they couldn't tell us whether it was from the hospital, from a patient, or from their own community or their families. When they've looked at it, luckily, most of the healthcare workers all across the world are younger and healthier than the general population, and 90% did not require any hospitalization. And of the 10% who did, 5% required ICU admissions, and mortalities were less than 1%. Now, we saw similar patterns of healthcare worker infections in Pakistan, starting with 253 healthcare workers on April 24th. Then the May 1st headline showed a jump to 200 in 1 week. And as per the United Nations Office of Coordination of Humanitarian Affairs, 1,900 healthcare workers had been contracting COVID by June 1st in Pakistan. Now, to keep healthcare workers safe and healthcare settings safe, WHO came up with a very comprehensive plan that focuses not only on healthcare worker protocols, but larger administrative and environmental issues that need to be addressed. It begins with use of universal precautions at all times with all patients. It then goes on to talking about early recognition through active triage of all patients so that suspected patients can be quickly isolated. It focuses on healthcare worker strategies such as appropriate PPE and special circumstances. And then it goes on to talk about governance and administrative support beyond the healthcare worker and the environmental controls to make healthcare facilities safe for all healthcare workers and patients. So starting with the first one of standard precautions, we really talk about the fact that we want to be able to provide care to all of our patients needing medical attention. And since we cannot test everybody who comes in at this point in time, following standard precautions has to become 100%. So as up to 20% of our COVID positive patients we know are going to be either asymptomatic or pre-symptomatic, universal precautions should be followed at all times in clinical areas. Now, this has to be due diligence and use of appropriate PPE and hand hygiene. So if you cannot have as many patients in the clinics, then alternate routes such as telemedicine through video conferencing and telephonic conversations will allow continuity of care for NCDs and other seasonal infections like dengue, malaria, and flu that we see. Screening of all patients is equally important. Now, screening tools have had to adapt to the changing epidemiology of the disease. When we started seeing COVID-19 at AKU in early January, we were asking people about the travel to Wuhan, China. Then we moved from China and Iran to international travel, to domestic travel. And now with the community spread, we ask more about symptoms indicative of COVID-19, even if the patient does not give any history of exposure to confirmed or suspected COVID patients. I think that screening is also an amazing opportunity for us to educate patients and identify where problems can be, because it's important for people to know that if they give the correct answer, it will not mean that they won't be able to get care. But by being responsible, they are becoming partners in saving others from infection. The third step is appropriate PPE. And of course, appropriate PPE really depends on the area where you're working in the healthcare setting. So for those assigned to COVID areas, special care must be given to provide maximal coverage to them. So they are supposed to wear surgical masks or N95 masks if available, gloves and gowns when coming in contact with patient, and face shield and goggles. Extra precautions if you're going to do any aerosol generating procedure, it's important for people to remember that taking the nasopharyngeal swab itself is an aerosol generating procedure. So needing a proper setting, which is well ventilated, and wearing face shields, goggles, gowns, and N95 masks is extremely important. Of course, we all have to remember that hand hygiene pre and post contact with the patient or the environment is extremely important also. The fourth thing is really about administrative controls. So while we expect healthcare workers themselves to be adequately motivated to wear PPE to keep themselves, their patients, and their loved ones safe, it's really important for administration to take ownership of this training. Because without training and refreshers on proper donning and doffing of PPE, what to do, what not to do in clinical and non-clinical areas, we are bound to make mistakes, right? Because when you are in high stress and high population areas, it is very easy to kind of forget to do one of the right things and one of the steps. It's also very difficult to work in PPE because when you're working for long hours, wearing PPE itself in the heat and humidity can make you make mistakes, and uncertainty and fatigue can of course take their own toll. Auditing for compliance becomes extremely important for leadership to know about knowledge and practice gaps, and equally important are surveillance systems. So being able to quickly recognize and identify healthcare workers who have the symptoms which are consistent with COVID-19, identify where they may have been exposed to, and do rapid contact tracing are all extremely important for us to prevent the spread of the infection. Finally, talking about environmental safety, of course, none of us could build new hospitals when COVID-19 hit us, but reassessing and replanning existing spaces can be done everywhere, even in your own clinics, right? So if you have areas, you should designate separate areas for COVID positive, COVID suspect, and non-COVID patients. And the staff for all three should be separate. Patient beds should be adequately distanced. Places where staff are taking care of patients should be well ventilated, and there should be appropriate spaces for aerosol generating procedure. And of course, cleaning and disinfecting protocols need to be created, followed, and taught to everybody who's taking care of patients. So now I'm going to share with you quickly about how we've been taking care of employee safety at Aga Khan University in Pakistan. So just to give people an idea of what AKU comprises of, there is the main campus that most of us have heard of, but AKU also has affiliated 4 secondary hospitals, which are women and children hospitals. We also have approximately 300 lab facilities all across the country with 20 integrated medical centers. There, care is provided. There are pharmacies associated with that. Along with that, there are academic areas. So there's a medical college, there's a school of nursing and midwifery, there's an Institute of Educational Development and an Education and Examination Board. So in total, there are about 13,000 employees working at AKU full-time, of which 70% are clinical and 30% have administrative and academic roles. So when we started planning for COVID-19, which was early January, even before it came to Karachi, there was a hospital incident command center, which was called HICS, which was set up. And the employee health and safety representative was an active member of the COVID command core group, just to make sure that we were always thinking of our employees and ensuring that their safety came first. A team was created, which was led by family medicine. I was leading it as the chair of the department. We had an ID specialist who was added to the team, about 4 nurses. We then added 2 junior faculty and then public health members from our faculty to help us with surveillance and coming up with better ways of making sure that we were taking care of the entire system. Now, none of this happens, of course, in silos. We, of course, have internal collaborators. The DIFI is the Department of Infection Prevention and Health Epidemiology. At AKU, human resources helped us with making policies which would help employees safeguard themselves. Marketing and communications helped with a lot of internal communications. And of course, the chief medical officer and the chief nursing officer were very active members of this team. So when we think about our framework, we looked at 4 basic steps. We talked about knowledge and self-reporting of symptoms. The second was daily active screening of all employees coming to work. The third was physical distancing, PPE and hand hygiene, but also their audits. And then finally, contact tracing of positive employees and creating employee health protocols for exposures. Let's start with the first one, which is about knowledge and self-reporting. So the first thing that we did was that we wanted to make sure that our employees did not feel that they were going to have to use their own leaves, and they wouldn't be, they would be penalized if they became infected or if they were exposed. So a policy was created by the university very quickly that they will not be, if an employee is in quarantine or isolation, the university will take care of their leaves and they would not be taken out of their earned leaves. it was also important for us to add in there is that if people got exposed or they contracted COVID-19, the employees did not have to pay for any of it. So the university made a very generous decision that all screening, testing, treatment of COVID-19, inpatient, outpatient, would be covered by the university directly, rather than people having to take it out of their own pockets and their health benefits. We also had a lot of supervisors training so that they would be able to quickly find out which of their employees were getting symptoms, and that people were not working despite having a fever or a cold or a sore throat, which is a very normal thing for us to do otherwise. And then, of course, we worked on the second part, which was the daily active screening of all employees coming to work. For this, we are, as I said, a large institution with a lot of employees, and for us to be able to do daily active screening in any other way was impossible. So we created an app. It's called the Sehat Check app, and people log in through their own AKU user IDs. Now, of course, not all of our employees have smartphones. So there is a desktop version of the same screening which happens at the same time. And as soon as people come into work, they can log in and make sure that they are looking at 4 basic questions. So they're looking for, have you had a fever in the last 24 hours, sore throat, cough, body aches? And then finally, if you've come in contact with someone who was suspected or confirmed to have COVID-19. We have an Urdu version of it because a lot of our employees don't speak English. And then if everything is fine, you get a green signal and you're fit to work. And you can show this to anybody who's walking around or to your supervisor to say that you're fit to work. But if you are unfit to work, if you say yes to any of the questions coming up over there, this red actually does 2 things. It will send an automatic email to your supervisor saying that you are unable to come into work today because you had symptoms consistent with COVID-19. And at the second side, it allows the employee health team to be able to look and say there is somebody who's unfit to work and they need to come in to the employee assessment area and get assessed and tested. So this is what employee health on my side this looks like. So an active screening happens. This was taken at 7 a.m. in the morning. So about of the 12,000 active employees who are working there today, 1,900 had logged in and did their Sehat Check app. Most of them were fit for work and about 16 of them were unfit for work. And then this 59 number also tells me, how many people from yesterday were unfit for work and whether their tests have come back positive or not. And then I can allow them to go back to work if they are fine and they don't have COVID. The third thing that we did was the PPE, hand hygiene, and physical distancing. So we came up with guidelines which really evolved with the understanding of the disease. Of course, in the beginning, we were just doing masks. And as we got to know more about the disease, we added goggles, we added, N95 respirators in areas where people were taking care of COVID patients. Not only did we do our own PPE guidelines, but we also did a lot of trainings and refreshers. And not only did we do training of our own employees, but working with the government of Sindh, there was a memorandum of understanding. We trained 7,000 healthcare workers across Sindh to ensure that they knew about proper donning, doffing, how to use PPE correctly. Because if you don't use it correctly, then you can certainly put yourself at risk. And just having a surgical mask or an N95 is never enough. The final thing that we've done is that we have mandatory mask policy for all patients, visitors, and staff. So nobody can come on the campus without wearing a mask. And I think that has made a significant impact to the number of cases that we are seeing. As I said, auditing is a very big part of it. So this is the CQPSO, which is the Chief Quality Patient Safety Officer who audits all clinical areas. And you can see that in May, we had a lot of reds showing up. This red over here, which says as expected, the 96% of patient wearing masks is because this is the pediatric floor. And in peds, the younger babies can't wear masks and you can't really expect them to. So that 96% was as expected, but our expectation was that everybody will remain 100%. And as we went into June, you see that there were more and more greens and fewer yellows and reds. And so, continuing to audit, continuing to hold people accountable and leadership accountable was extremely important for us to get to a point where everybody felt safe. Finally, talking about surveillance and care and employee health protocols, which is what our system was, creating a surveillance system in and of itself is a huge feat. Rapid contact tracing within 24 hours is extremely important. So we looked at a pool of volunteers from the entire institution, so from departmental areas, who were nominated, who we called COVID protectors. And these are the people who we trained in all exposure guidelines, so that if somebody came COVID positive, then they were able to go within their own area and find out exactly how many other employees had been exposed to this particular person, and quickly let employee health know, and so that we could quickly assess them and could quarantine them and then isolate them if necessary. We also created a 24/7 hotline, which was manned by our nurses, first from our Sonam faculty and then by our NES nurses. So anybody who identifies and who's worried that maybe I have COVID because I have a sore throat or I have an exposure, they can have self-identification. They can also have a rapid assessment of exposure risk. We've received about 5,000 calls in the last 3 months on this 24/7 hotline, and been hugely popular and very, very helpful for employees. And finally, we had to create a database, right? Something where we could look in real time and document those who were exposed. And that allows us to identify outbreaks very quickly. So that if I'm seeing a pattern within my system of I've got 3 or 4 people from a particular department who are turning out to be positive, I would quickly go ahead and inform the DFE team so that they could go ahead and decide whether there's an outbreak investigation required or not, whether infection control practices need to be changed, and for us to improve our policies as an institution. Finally, there's a steps in contact tracing that everybody should know about. We talk about definition of contact tracing. So, being in prolonged contact, and it has to be 48 hours before the test or before symptoms come in a COVID positive person. Once it's defined, then you want to identify, we obtain the list of people, we interview every manager to discuss, if there is somebody that we're missing, and then we use records like bookings, etc., patients who may have been exposed to somebody who was COVID positive, so that we can quickly pick up everybody and quarantine them after identifying them. So informing is really important, where to quarantine. So for our employees, many of them don't have large houses where they could have a separate bathroom and a separate bedroom. And so we had to create facilities where employees could quarantine safely, and the institution did that at no extra cost to our staff. What are the symptoms they need to look out for, who are to report to, and data protection, of course, is extremely important. And then finally, to manage. So quarantining them, daily monitoring, staff knew where to call us. So they would call the employee hotline if they started feeling that they had any symptoms, or we would call them on day 3 and day 7 from employee health to ensure that they were not developing any symptoms. We also developed a whole system and protocol of how we would manage our employees. And this protocol really depends on whether you've been exposed or whether you have symptoms or not. So if we look at the exposed side, we were using the CDC criteria to decide if somebody had a high or a medium exposure. And if they did, we would quickly do a COVID test on them and put them in quarantine. If in 7 days of quarantine, their test was negative, they would get a retest. They would test, and if that was negative, they were allowed to come back to work. If, however, after the quarantine, their test became positive, then they were isolated and the employee health protocols were used for COVID treatment. If somebody is low risk, we just tell them to not test, just self-monitor for the next 14 days or so, and they were to use the Sehat Check app. Now, people who were already symptomatic, who had symptoms consistent of COVID-19, either picked up through the employee hotline or through the Sehat Check app, they would immediately get a COVID test, no questions asked. And if they were positive or negative, that would then make us decide when they could safely return to work. And then finally, as I said, the whole idea, the ethos behind everything that we did was to ensure that employees and our healthcare workers felt safe, and they felt safe to come into work, and they knew that they were being taken care of. So safe spaces were created to quarantine and isolate it. We did safe and early return to work guidelines. So we used the shortened 7-day version rather than waiting for 14 days, because we really couldn't afford to take out such a large amount of workforce. We wanted to support them during quarantine and active follow-up. And then finally, for people who were COVID positive, again, we had to create isolation facilities. People had elderly parents at home, people had young kids at home, and they didn't want to stay at home if they were COVID positive. And then every 3 days, there was a tele follow-up by a family medicine doctor to ensure that they did not require any admission or coming into the ICU to the emergency room. Our return to work policies changed. We moved from the test-based strategy to symptom-based strategy. and really recognizing what are our spaces where we could have more difficulty. So for example, in our oncology unit, of course, we still continue with the test-based strategy. So people have to get 2 tests which are negative before they can come and work with immunocompromised patients. The same goes for our rheumatology practice, where a lot of people are on DMARDs and are immunocompromised. But otherwise, we completely moved to a symptom-based strategy. And then, we wanted to create a culture of empathy. So we had supportive policies. We did a lot of advocacy with the university to make sure that testing, treatment, and leaves were all covered. We created safe environments so people felt safe in coming into work, clinical and non-clinical areas. We did a lot of training and refreshers. We responded to their social concerns. And then finally, this is a little thing, we did a lot of leadership training. How to make leaders and middle managers keep employees' confidentiality, how to support them if they become positive, how to support them if they are isolated or they are in quarantine, and how to build that feeling of trust amongst them. Because COVID has become a huge taboo in Pakistan, and a lot of people wanted to hide it. And for us to have a safe university and a safe hospital, we had to become very open while respecting people's privacy. And I think that is something which has gone a long way in making people come forward and talk about their own symptoms, talk about whether they have been exposed, and take care of themselves. So I will stop here and I will pass it on to Dr. Yousuf to share his experience about COVID. Thank you.
Thank you very much, Dr. Unab. That was excellent presentation. Before we go to Dr. Yousuf Haroon, I would like to recognize and welcome Dr. Naheed Usmani, is APPNA's president. She has joined us, and she has done lots of work for family medicine. She's a great supporter of family medicine, and she's helping leaders like Dr. Unab and others in Pakistan, and she would love to develop family medicine program in Pakistan. That was also her initiative as a conference in family medicine in March. That was a great initiative, and these all series, APPNA MERIT and family medicine webinars, that's her under her leadership, and her response to APPNA's response to COVID-19 is under her leadership is exemplary and has been recognized by government of Pakistan as well. Naheed Usman, if you wanna say a few words, please.
Ji, Assalamu alaikum everyone. Thank you so much, Zahid, for that very kind introduction. So really loved Dr. Unab's presentation. I think it is remarkable how similar my experience at University of Massachusetts is for the COVID policies to what AKU is doing. We, it's almost identical. I think as healthcare workers, it's very important to recognize that COVID is not a single episode. A vaccine is not going to be a cure. We have learned how to take care of COVID patients much better than we did initially, so that our mortality has gone down, but the infectiousness of the virus, the spread of the virus, unless we continue to protect ourselves, we will continue to have it within our communities, our hospitals, our countries. I think we will have a peak and an ebb, but this virus is going to be around for many years. So we are in a healthcare environment where masks, universal masking, is going to be the norm of the day for the next few years. And we will have to continue with hand hygiene and social distancing and protecting both ourselves and our patients and our families, because we are frontline workers. I remember that I volunteered at Children's Hospital in Lahore a decade ago, and I was volunteering in the pediatric oncology unit there, and they did not have running water, so there was no concept of washing hands in a tertiary care public hospital. And that was one of the first things. Rather than teaching oncology, all I did all month was harp that hand hygiene was critical for decreasing septic rate when you're giving chemotherapy or you're treating patients with leukemia and lymphoma. So these are things that all of us on this forum, all the primary care physicians have to advocate for, have to preach for, have to incorporate it in day-to-day practices. Every day, as a reflex, just as namaz, I log in into my daily employee health report and report that I'm healthy and I'm coming to work. I think these are personal responsibilities. So Dr. Unab, that was wonderful. Thank you so much for your presentation. Thank you, Zahid. Continue the fabulous work that you are doing. Primary care is the basis of all healthcare across the world. Thank you.
Thank you.
Thank you, Naeem. That was great. And thank you for your continuous support for family medicine. So let's move on to Dr. Yousuf Haroon Ahmad from Australia. It's nice to have an Australian family physician here with us. Dr. Yousuf Haroon Ahmad is a family physician from Australia, Chairman Board of Directors, RWAV. He's a counselor, RACGP, and Managing Director, English Medical Center. And he's a chair of Australian Association of Pakistani Physicians. Welcome, Dr. Haroon. Please continue with your presentation. Thank you.
Assalamu alaikum, everyone. Thank you very much, Zahid, for your kind introduction. And thank you, Naheed, for your great motivational words. And I think Unab has set the scene very well for my presentation. And she has talked about all the best practices, the WHO guidelines, and as well as the local guidelines we are following here. So I'm actually going to just apply those guidelines in a model in form of our general practice in Australia. And just to see that how they are applicable in community setting. So just to start, to provide some context, so this is our general practice. On the right side, you will see our statistics. It's a practice of about 44 staff members. We are 15 family physicians or GPs, which include about 6 to 8 trainees at a time. And we have other services along with that. Just briefly about general practice in Australia, that the general practices are all actually small businesses, and they are independent businesses, and they run as fee for service, which can be private or generated from Medicare. And therefore, the funding model of the general practice is very important and part of the safety and security of practices as well, we will talk about. And the GP not only do just the practice role, but they also provide visiting rights to the hospital, looking after their own patients, and services to residential aged care services and other associated community services as well. We talked about the safety and security, and Unab has already highlighted many of these concepts, so I'll very briefly go through. When we talk about the health safety, we usually talk about the health workforce safety, but there are actually many different aspects of that, and I've just tried to capture some of those concepts here in this diagram. So along with the physical health, of course, the mental and social health of the workforce, it is also important the safety and security of the business and the processes. Just an example, because of the COVID-19 and changing practices, most of the general practices in Australia had a loss of about 50% of their business because of the patient turnover has reduced significantly. The structure and buildings are very important, and as Unab has highlighted how important it is to manage the flows of the patient, and as well as make the structural changes to ensure the safety of the staff as well as the patient. Patient community is an important factor, of course, their own safety, but as well as they impact directly on the safety of the staff as well. And then when we talk about safety, we just don't talk about the medical aspect, there is also legal and ethical aspect. As Unab was mentioning, and we see here as well, that's quite important. For example, if somebody is positive, and I'm talking about even a patient in a small network community, is very important that data is confidential. and it doesn't reach the community level, because there can be repercussion, as people have seen all across the world. Just as an overall concept, the governance and strategic planning of this pandemic, when it started, we took a regional approach. And as mentioned earlier, that family physicians are the leaders in dealing with this pandemic. In my view, the public health and primary health care are the basis of dealing with pandemic of COVID. And we took the regional approach in the sense that we joined hand with other practices and all other services. And we actually formed a pandemic group, which I chair in our region. And we also restructured our management structures for our practices. Workforce planning is an important aspect, again, to maintain the health and safety of our workforce. So we actually divided workforce into different groups to ensure that if there is some positive case and one section of workforce is actually not able to work, we can still maintain services in the practice as well. Facility planning is also important. If we have a positive case in the facility, or if there is a significant exposure, the facility may shut down. So you have to plan for alternative to still provide the service to the community. Business and financial planning is also very important. As I mentioned, that if the business shut down, there is significant loss, and there can be loss to the employment of staff members. Because of the COVID-19, we had a large number of practice nurses who lost their jobs, and that's part of their security and safety as well. I think risk, I don't need to elaborate. There are many aspects of risk already captured here. Just to very briefly capture the regional pandemic group, which include our general practices across the region, as well as 3 hospitals. We have Air Force Base, correctional facility, as well as different municipality in our pandemic group. Safeguarding the health facilities. As I mentioned about the building and structure, right from the start, we decided to divide our practice, literally build a wall. We love building the walls. So we built the wall to separate completely the facility. So we have any person with respiratory symptoms actually seen in a different part of the facility, so we can protect the staff as well as protect the vulnerable patients and keep the flow of the patient separate from others. And we have very effective triage system and also linkages with other facilities. If the people are unwell, how they can be triaged and expedited to go to the other facility where they can be looked after. This is just the quick diagram where we divided, and this is the area where we created actually a COVID clinic, or what we should say, a respiratory clinic. Now, this is a concept, as Zahid has mentioned, that this pandemic is not going to finish now. It's going to last for many years. So we actually now are building a customized infectious disease center in this area, because this is something which is probably going to stay in general practice for many, many years. And hence we can protect the staff as well as our patients from infectious diseases in future. So as soon as the pandemic was announced, of course, we had to make many structural changes. We divided the flows. We created the screening system. Unab has highlighted so well. We created the screens to protect the staff. We changed our booking systems as well as most of you know that most of the practices now, we do mostly teleconferences and telehealth. And if there is a face-to-face appointment, there is quite a number of triage system before patient can come for a face-to-face appointment. Social distancing measures were implemented in the waiting rooms. We limit the number of patients who can come in. We reduce the traffic into the practice, as well as similar principle applied to the staff areas as well. So there can't be more than, for example, 4 staff members in the conference room at a time, and they cannot stay here more than 10 minutes, etc., etc. We did a lot of cleanup and infection control measures as well. This is just an example, and there is no need to look into details. We created patient journeys, and I think it's quite important, the communication among the staff, among the patient, among the community. One thing we have learned, the communication is essential, and it has to be very rapid. So we created patient pathways, that what their flow can be through the respiratory clinic. And if they have to go to the hospital, we have linkages with the hospital flow as well. So everybody can understand what is the next step in case if somebody is unwell or is COVID positive. Talking about the workers' own health and safety, we had 6 approaches Of course, plan and consult. So we engaged our staff in different groups, like nurses and doctors and reception and medical staff separately. And we consulted with them on an ongoing basis, which we still do nearly every day. Preventing the spread, safety and security, I think we have already talked about the PPE, but I think the other thing which I would like to highlight is the violence and aggression. And this is something which has been experienced all across the world. We see that here in Australia as well. We had a sad example. Zahid mentioned that a family physician was stabbed in his locality recently. Last Friday, we had a breach in our own clinic as well, and where we had to involve the police and security as well. Information to the community is very important, looking out for each other and also looking after the vulnerable as well. So in terms of planning and consult, right at the start, we divided our management structures, where we actually have a separate structure for the respiratory clinic, which is not dealing with the rest of the general practice, as well as different guidelines and protocols was created. I'm not going to go into any details of those here. To prevent the spread, I already mentioned about telehealth. We had targeted care for vulnerable patients, especially the elderly, the cancer patient, the palliative patients. We had protocols specifically for those groups, and we had separate flows if they have to come for face-to-face consultations. We also did a major drive of flu vaccination at the start of winter here, and that was quite a bit of effort, where we did thousands of flu vaccines through the practice as well. And we did spring cleaning right at the start. We could not believe how much clutter we had to remove from the practice. So there is no surface which can't be cleaned within few minutes, and which has to be cleaned many times every day to control the infections. PPE, we already talked about infection control measures. Right from the start, we engaged the police. So we have a dedicated police line as well as dedicated security for the staff, which is absolutely essential to protect the staff as well as safety and security of the actual establishment as well. Informing the community, I think we used probably every form of information to community through media, TV, social media, politicians. We targeted the schools, Air Force Base and prison, especially because they were community of interest, as well as utilized community networks and organizations. The CALD, which is basically the communities who are more diverse communities, let's say the Asian communities from Pakistan and other communities, we had specific communications for them in their own language. We developed a lot of protocols, especially for Muslim community through our Muslim organizations to provide them guidance regarding burial during COVID and other issues which are directly relevant with COVID as well, which is an important part of the community's understanding, as well as our staff. Many of them are Muslims as well. Looking after each other was a very important part. Yes, we used to come to work in suits and ties, but we look very different now, and that's all changed because of COVID. But right at the start, we appointed our mental health nurse and psychologist to be available for the staff and do the health checks regularly, as well as looking after each other and reporting if there's anybody is not feeling well or not doing so well mentally or psychologically as well. Looking after the vulnerables, as I talked about the workforce planning, we asked the staff and they self-identified if somebody is vulnerable, if they have, let's say, diabetes or they are elderly staff members, and we organized a modified way of consulting, some of them working from home. We also separated the workforce of doctors who are visiting aged care or hospitals from doctors who are working in the respiratory clinic. So there is less risk of carrying infections, and as well as stopping or reducing the risk of infecting each other. Along all this pathway, of course, we had a lot of education and training. This is just one of our training seminar after our PPE training session, but never forgot the fun. Thank you very much. I'll be very happy to answer questions later. Thank you.
Excellent. Thank you very much, Dr. Yousuf, Haroon, Ahmad. That was an excellent presentation. I love the last slides. Of course, we should have fun because, as you said, this pandemic is here to stay. And of course, we have to wear masks, have distance. let's not forget to have fun. And I've seen lots of creative masks. People are wearing different logos and different things written there. All right, excellent. So we'll take question and answers at the end. And let me introduce our last speaker for today, Dr. Abdul Waheed. Dr. Abdul Waheed is a program director, family medicine residency program at WellSpan, Good Samaritan Hospital. He's a clinical associate professor of family and community medicine at Pennsylvania State University College of Medicine, Philadelphia College of Osteopathic Medicine. Welcome, Dr. Waheed. Please continue with your presentation.
Thank you for the introduction, Dr. Zahid, Rafiq. And so both of my esteemed colleagues, Dr. Yousuf, Haroon, and Dr. Unab had wonderful presentations, and they have covered all the concepts. I'm just going to comment on a few of the themes, like how we went through. They have covered all the conceptual framework already. So my unit is basically 88 employees, including the clerical staff, the nursing staff, and residents and faculty. But I'm part of a very large organization, WellSpan Health, which employs 2,600 physicians and advanced practice providers with more than 200 patient care locations and 8 hospitals. And out of those 8 hospitals, 6 are acute care hospitals. So we, as an organization, from the top leadership from our CEO, had a centralized control and command center who looked at various aspects, including the employee safety and patient care protocols and dissemination of information to the public and to the employees. Communication, as was said earlier, was the main and cornerstone. And at the organization's central command center level, there were twice a week updates at the lunch hour and in the morning, which were kind of open to everyone electronically. So the virtual meeting platforms were the cornerstones. And then within my own program, the challenges were met in a way that I had daily safety huddle with my team. So 7:30 to 7:45, everyone will come on the virtual platform, and we would disseminate all the information from every corner of the organization to everyone. And that was the key in keeping everyone on the same page. And when we talk about healthcare worker safety, healthcare worker definition, Dr. Unab Khan touched upon it. In my area of the world, you know, my specialty and the work that I do as residency program director, I have employees who have 2 hats. Either they are, you know, not only providing care, they are teaching or they're learning. So, and then the third category, so those are faculty and residents. And then the third category, who I also consider healthcare workers, is the medical students. So for a brief time, the medical students were kind of taken out of the picture. But now that we are going back into coexistence into COVID, they're being brought back into the mix. So 3 things that we looked at from the health safety perspective: PPE. There was a physician-led committee in the Central Command Center who looked at the personal protective equipment and looked at the guidelines and disseminated that. And then skill development. Again, for physicians and healthcare workers who are already at their home base, for example, they're working ICU and or in the hospital, and then in the outpatient offices. And then those who would be redeployed for in the areas of need. And then the third pillar was wellness. And for wellness, again, the human resource already has a program called Employee Assistance Program. They upscaled it and made it available all the time, 24/7. And then they added another peer support line along with the Employee Assistance Program. And it worked very well. In my own unit, we had only one APP who contracted, and it was community acquired, not through the workplace. And thankfully, all of my staff, my physicians, my residents and students remained safe through the large wave. And now we are in the reopening phase 3. We have almost reopened everything. And now the focus is on screening, surveillance, and rapid communication again. 3 things. And protocols are very similar to what Dr. Unab Khan and Dr. Yousuf Haroon shared. So I'm not going to go into a lot of detail. Right now, the surveillance program really is based upon screening people with the contact through EMR. Anyone who opens the EMR, for example, patient comes in for heart failure symptoms, and now all of a sudden becomes positive, and those who came into contact with the patient, they are done through the any contact within the EMR. And so the tracer goes out, and then there's rapid communication to those people. And then other staff who are clerical or housekeeping, or other staff who might not actually open the EMR, but might still have contact with the patient. So there is a process and workflow based upon the shift they might have contacted. So that's all I have to share, but happy to answer any questions afterwards if there are any specific.
Excellent. Thank you very much, Dr. Waheed. That was great. So I think if there is anything else from you guys, otherwise we can move on to Q&A session. Is that okay, Dr. Unab?
Sure.
So you have some of the questions we're seeing in Q&A box. You have answered one question. So just elaborating on that question from Shazmi Khan. Basically, they're asking about mask, when to wear mask, how, if say inside or outside you have to wear mask. Dr. Unab already answered the mask should be wear all the time if the distance is closer than 2 centimeters. And I'm not sure if it's because we are in different jurisdictions. Like in Canada, we have the same rule, mask should be worn. It's mandatory in closed spaces, in shopping malls, in even city facilities. In the clinic, we have mask mandatory. They should patients should sanitize their hands, wear masks. Australia, I'm not sure, Dr. Haroon, if you want to comment on that, and Dr. Abdul Waheed in America, if there's any different. First, Dr. Yousuf, in Australia, you have any rules there?
As you know, in Australia, especially in Victoria, unfortunately, we have the second wave, but really it's the first community wave in Australia right now. So in Victoria, we now are, the Premier has declared state of disaster. And because of that, we have compulsory mask everywhere. So if you leave the house, you have to have a mask. We have quite severe restriction. In Melbourne, you actually can't get out of the house until it's essential. Where I am, we can leave the house, but with a lot of limitations. So masks are compulsory everywhere anyway. Along with that, in practice, we have had masks, of course, compulsory for a long time. The guideline as they are 1.5 meter. So you must maintain that social distance, keep the mask on. Now, as Unab has already mentioned, the eye protection is also essential for all practices as well. So that's what they're doing in Australia.
Excellent. Dr. Waheed, is anything different in America? Of course, there are different states, and some states are dealing with very well, and some states have totally different rules, or there are lots of people who don't believe in COVID as well.
I would love to hear this answer.
A lot of challenges. So I'm not sure how I'm going to comment on this, but I'll tell you what happened in Pennsylvania. So Pennsylvania, it was exactly the weekend of the last weekend of February, and we had Pennsylvania Academy of Family Physicians annual conference. And it just happened to be that the Pennsylvania Academy of Family Physicians honored me with the with the Teacher of the Year award for the Pennsylvania for medical education. So we were there, and the person who got award for the public health advocate for family medicine for the state of Pennsylvania started in his speech and said that there were 2 cases already in Pennsylvania. And we were like, wow, Pennsylvania has 2 cases now. And that was when there was no community spread. And lo and behold, we were just bracing ourselves. And one of the things that I really applaud about WellSpan Health is they, right then and there, they had 2 cases, only 2 cases, and none of those were in the 5 counties that my organization provides care. But they started the centralized command and control center right away. Start looking at procedures and policies, and lo and behold, March 12, the community spread was declared already. So it was like within 2 weeks, there was community spread, significant community spread. And the governor of Pennsylvania took a very strong stance and declared a disaster level 3 emergency. and only essential workers were allowed to get out of the home, and everyone was to stay homebound. And then there is a long story, you know, how it kind of phased down to where we are right now. All the businesses are now open, and now they continuously track at the state level in terms of the case positivity rate from the symptomatic, as well as the ones who are being tested asymptomatic. Now that we are phase 3 reopening, all the surgical centers are open, the procedures are open, the patients are being tested before they go into procedure. And when they test them, they're basically asymptomatic. So our county rate is close to 1% in terms of asymptomatic still now. But the symptomatic ones who get into our infectious centers, like the one Dr. Yousuf Haroon was pointing out, we already have those, what some people call COVID caves. Those are the clinics designated for the COVID care. And the others are for regular care when patients are asymptomatic. So the data from there is 3.5% in the range, 3 to 4% positive rate in the past 2 weeks. So we are over the first wave completely, but definitely there's continuous community spread, and we're trying to coexist. You see me, we are back into the suits. I'm on the call coverage for a rehab hospital, and all I need to do is my rehab hospital does not have any positive cases. Everyone gets tested before they get downgraded from the acute care hospital into the rehab. So I just put on my white coat, take my jacket off when I go into the patient care area from out of my office, and put on my mask, and I already have this, so I don't put any extra. If there's a positive patient, there's a whole PPE and gear, which is kind of indicated per protocol. So that's how we have done it. And there are different states who are doing things very differently, as rightly said. And there are all kinds of political entanglement of the concepts. Right now, I'm going to try to persuade myself away from commenting on those, but it seems like, somehow some of this has become a political issue. And it's interesting. I talked with my residents when in training, and we have a 200-hour-long health systems management, leadership, and advocacy curriculum that runs from PGY 1 to PGY 3, like all 3 years. And we talk about some of these concepts, like how healthcare exists into systems, and the systems, the community systems, the family systems, the healthcare system, and how they interact. And I have a very interesting Venn diagram that I show them. And this is a perfect example where the community systems, where there are belief systems from religious aspect, from cultural aspect, from political aspects, and how they actually can come and rattle the healthcare systems and society in general. So I'll stop there.
Oh, very well. Thank you. Thank you very much, Dr. Waheed. So another question stems again from the mask wearing. In the clinics, when patient comes, it's mandatory for them to wear masks. So how each of you is dealing with if patients are refusing to wear masks?
I'll first on that. So we have a standard policy, and we have a screener, continuous screener outside. And anyone who comes without the mask, there is mask that we provide. There is a screening call that goes to patients who are already scheduled and screen them for the symptoms. Exactly the same symptoms that Dr. Unab Khan actually presented in the Zahid check. And that's documented in the EMR. And then when they enter into the office at the day of their appointment, there's a screener outside in full PPE who screens them again for the symptoms and makes sure the mask is there. And if the mask is not properly put on, it's like sort of sometimes you see, it's really not a face mask, it's like chin guard, right? So the patient is educated, and if someone refuses, then we refuse the entry into the building. And then there are standard procedures like to involve security and other departments if need be.
So no mask, no service. Okay.
No mask, no service.
Dr. Unab, what's your experience in that?
Yeah, pretty respectfully educating public before they come on campus, and letting them know that they will not be allowed, offering them a mask. So we have made masks available from the first security check post all the way inside, outside the clinic area. But also letting people know that this is not because we don't want to give you care, but this is to keep you and others safe. And just passing that responsibility to patients that you're wearing a mask can save somebody else's life goes a long way. So, we constantly educate, constantly train, but there is a zero tolerance. So if you're not going to wear a mask, you really cannot come within the hospital area and expect to get service.
Excellent. That's a great point. You might not get the disease, but you can transmit to others who are vulnerable.
Yeah.
Dr. Yousuf, anything?
I think nothing, same probably like my other colleagues. No mask, no service, simple. But I think most of our work has been done by our admin staff and reception staff. Actually, they have been educating most than anybody else because they are the front line. They are the first contact. As I talked about the structural changes, so we ensured that in our facility, we may have 2 or 3 exits, but there's only 1 entry, and hence they have to go through that process. Through community, through education, I think we have utilized every source. So nobody can actually say that I did not know when I was coming here. There are exceptions though. If somebody has severe chronic airway disease or severe heart failure, and they may have exception to put on mask because it is hard if the oxygen levels are already very low, but we do offer them face shields in that case.
Excellent. That's great. And Dr. Yousuf, through your last comment, like people who have already pre-existing conditions, asthma and other things, they are exempted. So some patients are requesting, please give us a letter so that we don't have to wear masks. So is there any set criteria, or will you be able to give everybody?
Look, very simple criteria we have, and that's our national approach actually by RSCGP as well. Our job is actually not give exemption. Exemption is actually legal issue, which is by police or whoever is the authority. Our job is to provide the clinical information. So what we do is that we write down this person has asthma, that's all. Or this person has COAD. And then it's up to the authorities to decide whether they will exemption or not.
That's
the other thing is, the other thing is also that people don't have to wear surgical masks, right? I mean, cloth masks can be worn by pretty much anybody. So you can create a cloth mask yourself. So letting people know that there are options available and it doesn't have to be it's not a one size fits all, has really helped a lot of patients too.
Exactly. Excellent. So that's a very good point again, Dr. Yousuf. And you mentioned that it's not our job to give them a letter. So our job is just to let them know what they have condition. And that I think is a very, very important point. And this saves us from having an argument with the patient. And that escalates into so many other things. And its safety can be compromised of healthcare worker or sports staff. So I think we should just say that you have this one and authorities can decide on that. Excellent. Next question is for Dr. Unab. I'm hearing lots of things like people are saying that in Pakistan, there's not going to be any second wave of COVID-19 because of herd immunity. Your comments on that?
I wish, everybody's heard about all the outbreaks that are happening in prisons, and certainly no herd immunity happening over there. In fact, what is scary is that we're already seeing reinfections showing up in sporadic cases all across the world. So I think that's a false hope. I think we all need to pray for herd immunity, but at the same time, do our due diligence. Wear the mask. It really is 3 simple things, right? Wearing a mask at all times, washing your hands and being careful about hand hygiene, and keeping some physical distance between you and the next person. Those 3 things can save so many lives. So, making that the norm of our life now and the way we live is really important, rather than thinking that this is the only thing I have to do if I get sick or if somebody else is sick. I think we have to change our mindset a little, all of us, all over the world.
Excellent. Very nice. So there was a question in Q&A box you already answered. And it was about young people getting, they're having symptoms of COVID for longer period of time after, they're initially positive, but after a period of time, 2-3 months, they're still having the symptoms and testing negative. So I think what the person who asking the question, what they're alluding it to is what are the long-term, is there any consequences of COVID positive patient, or is there any other symptoms will continue, or they will develop any other diseases or so?
I think we don't know enough about the disease yet. I think we're slowly learning more and more. So for example, till about 2 months ago, we didn't think, but now we know that there is hypercoagulability, and we're already seeing young people coming in with strokes after having been COVID positive. I think there is going to be some element of a chronic fatigue syndrome kind of thing. We always see that more in the young than in the older people. It hasn't been defined yet in pediatrics or in any other population so far. But having massive hair fall, for example, after a severe viral illness is a very common phenomenon. I mean, I've been going into the telogen phase after acute stress is very common. I think it's also important for us to recognize that fatigue is an important symptom of distress and stress also. So people feeling fatigue after they've had a brush with something which was life endangering in their mind can really put them on that path of, oh my God, what is this going to do? And put them in that anxiety and stress kind of mode. So kind of looking at their mental health is going to be important, but I'm sure there'll be a case study or a case series coming out soon of people having long-term sequelae and just fatigue and symptoms after COVID positive.
Excellent. Thank you very much. We are 7 minutes over time, and I see Dr. Haroon, Yousuf Haroon, is already 1 a.m. there in Australia. So I think we should end this session. I would like to thank Dr. Unab, Dr. Abdul Waheed, Dr. Yousuf Haroon. Thank you very much for your presentation and sharing the knowledge. And the bottom line is, as Dr. Unab mentioned, wear mask, 2-meter distance, frequent hand washing, and inshallah we can pass through this phase. Thank you very much for attending. Thank you.
Thank you.
Thank you very much, everyone. Good night.
Thank you.